we have 4 simple rules. Number 1, we don't discuss politics, ever. Number 2, this is not a religious channel, and while you might hear people say, God bless you, or I'm going to pray for you, or I wouldn't have gotten through this without my faith, that's fine. What's not fine is to say, my God is better than your God, or here's why you're not getting into heaven. It's not going to fly. Number 3, we believe wholeheartedly if you can't control your tongue, then you can't control your life. So while on board, there's not going to be any cursing in the live chat, period. And number 4, there is no room for mean people on the lifeboat. Because we discuss very sensitive things from people's past in our group setting, we got to protect those people. The only way they feel confident and comfortable discussing those things is in an environment that is free of trolls and mean people. So if you're a mean person or you're a troll, we're going to block you for life. And if your account happens to be less than 24 hours old, we're probably a little suspicious right from the word go. Why? Well, because there are people in this world who enjoy being cruel solely for the sake of being cruel. It's not going to fly here. But if you're here because you're trying to get sober and live your best life, then you might find that the lifeboat is just that, a lifeboat. I'm Captain Tommy Scoville, and we will see you on deck. Hello, everybody. I'm Captain Tommy Scoville, and you are on the lifeboat. People, this is a good one. I've been looking forward to this for a long time. You know, when you watch the lifeboat, one of the first things that I say, especially if we're going old school, is I'm not a doctor. I don't play one on YouTube, and you know, there is really nothing that takes the place of talking to a medical professional because, you know, obviously, while I was off getting high and doing stupid things, medical professionals were spending an awful lot of their life, you know, studying and learning the absolute most that you could about everything that I speak about. But today we're honored to have Dr. Jetmore here, who's can lend a great deal of credence to things that we talk about here on the lifeboat. And this, fortunately, has he has spent a good deal of his time in his profession dealing with addiction and what that means. So this is a good one, people. I'm really, really excited. Dr. Jetmore, I'm so happy that you're here. If you could tell everybody a little bit about just a brief intro about who you are and sort of how you've some of the things you've done in addiction, so that we can sort of go from there.
Yeah. Thanks for having me. I'm glad to be on your show, Tommy. My name's David Jetmore. I graduated from IU Medical School in 1977. I'm an old guy. I'm a board-certified head and neck surgeon, and I practiced medicine until I was about 70. Now, I still take call, but shortly after I quit seeing patients, I got a phone call from a corporation called Groups that treats that has buprenorphine clinics and Suboxone clinics, and asked me if I'd like to be a doctor with Groups. And I said, I'm a head and neck surgeon. I don't know anything about treating addiction. And they said, well, you can learn. So in order to prescribe buprenorphine, you have to take a course to get that added to your medical license to prescribe. And so I took that course, and I was changed by that course. It made me view addiction totally differently. It wasn't part of my world before. You know, I was a scalpel guy. You came in with something bad, and I cut it out. And you hopefully lived happily ever after. And I didn't know a lot about, basically next to nothing about this. I began to see patients in Connersville, Indiana. Then I began to see patients in Richmond, Indiana. And I did that for probably 4 or 5 years. And I really came to enjoy it. I really came to enjoy seeing the people, seeing them get well, seeing them prosper, seeing them go from living on a couch in their mother's house to getting a job, getting an apartment, getting married, buying their own house, and doing what we all want to do, which is live well and prosper. And to be part of that was really invigorating. So I've enjoyed my experience in treating people with drug addiction. But that's pretty much where I'm at, Tommy.
Excellent. So one of the things that comes up a lot here on the Lifeboat, Doc, is that there's been a sort of a running debate on whether or not. I have always maintained that drug addiction is very much a disease, and the argument that I usually give is because people say you make a choice and those bad choices turn you into a drug addict, and I've always said that there are bad choices that can turn you into a diabetic. But you don't say that, diabetes too, isn't a disease because you've made, bad life choices that maybe led to that. But how do you view the addiction as a disease kind of a thing?
Well, first of all, what is a disease, Tommy? It's when something is abnormal about your body. In the case of a diabetic, as you mentioned, they've got an abnormal pancreas. In the case of somebody with high blood pressure, they've got abnormal blood vessels. In the case of someone with high cholesterol, they've got a liver that's not keeping their cholesterol at the right level. And in the case of people with drug addiction, they've got abnormal opioid receptors in their brain. Now, that could be from a bad decision they made, or they may have been addicted by their doctor. That may have been a totally normal person. When I say normal, somebody that doesn't have drug addiction, who was driving down the highway. They were in a car wreck. They broke both arms, 5 ribs in their pelvis. Their doctor puts them on oxycodone, and guess what? 6 weeks later, they're a drug addict. But there's no doubt in my mind, that drug addiction is a disease just like any other disease, and the treatment, and it has a medical treatment for it. Now you can quit taking. It's possible for you to just by sheer willpower not quit using narcotics and become and deal with your drug addiction problem that way. And probably the number of people that can do that has been estimated to be about 2.5% of people can do that. And I'm not probably one of those people. I mean, it took me 30 years to quit smoking. So, and I still haven't been able to give up wolfing down a pint of ice cream every night if the urge hits me. So, all of us have certain addictive tendencies, but there's no doubt in my mind that drug addiction is a disease, and people should not feel like that they're bad people, or they're morally weak people, or they're different than anyone else in society. They're good people. They're good people who have a disease.
Yeah, well, you know what? I felt the same way, and as I said, we've gotten a lot of pushback about that. I think that maybe it's part of how society views addicts, and there's just some weakness in people. But I've been real open with everybody here on the Lifeboat that my addiction was heroin. It didn't start as heroin, but it led to that as insurance companies cut me off of the prescriptions that I was getting. At one point, I was getting 12 OxyContin 80s a day. I was a former North American ski team member, so I had a lot of injuries. And one day the insurance company just said, look, we're not paying for this anymore, and that was the end of that. And I tried a lot of different ways to get sober. I tried the 2% method, where I just was going to, white knuckle and willpower my way through there. And after about 20 years of trying that about, once or twice a month and then failing and going right back to using, I started trying to do methadone and ran into a lot of trouble with methadone. I think primarily because of how they distribute it, but probably having something to do with the drug itself. And buprenorphine for me has been literally the holy grail. What it's enabled me to do to get my life back. Now I'm a homeowner and now I have a business and, I do the lifeboat and just all of the things that a normal person might do. Can you talk to us a little bit about the difference between methadone and Suboxone?
Well, both of them affect opioid receptors in the brain. And there are three receptors, mu, kappa, and delta. And basically methadone is a full agonist against all of the receptors in the brain. I mean, and what I mean by that is it stimulates the fullest ever receptor in the brain. Buprenorphine stimulates the mu receptors and totally blocks the kappa receptors. Now, when I get into this, I feel like people who are listening are thinking, "Gosh, I need to get a medical physiology book or a brain anatomy book and start looking where these receptors are." But what all this means is it's much easier to get off of Suboxone should you decide to get off, and you're not getting this huge buzz from the Suboxone. And the other thing that opioids tend to do is, you take 10 milligrams, the effect of that 10 milligrams mitigates over time. So now you need to take 15 milligrams, then you need to take 20. You don't have that with Suboxone. You take basically 16 milligrams, and there's really no evidence that taking more than 16 milligrams is particularly helpful to you. But what happens is you take the 16 milligrams, the cravings that you would have disappear. You're able to get up, and the main thing is you don't have to appear at a clinic every day to get your Suboxone. You get a prescription. It's a legal medication. The drugstore fills it. You pay for it, or your insurance company pays for it, and you take your Suboxone that morning and you go on with your lives. And I think most opioids wear off after about 4 hours, and you feel great that first 2 hours, and the last two you're thinking, where am I going to get more opioids? Where am I going to get more Oxycontin or whatever your opioid of choice is? So I think that's a game changer. You go, and the other thing is the milieu in which you receive the Suboxone, because you got a doctor that's prescribing it, and he cares about you. I mean, you're a patient of his. He wants to see you do well and not relapse. And the same is true of your counselor. You'll spend a day a week with other patients who are drug addicts, and you will. Everybody wants you to succeed. Your doctor wants you to succeed. Your counselor wants you to succeed, and your fellow people want you to
Absolutely.
to do well. It's a group effort, and people take joy in seeing every little thing that, somebody gets a promotion at work, somebody buys a new car, somebody's having a baby. Just these little life victories are shared with people who have the same problem, but people who care about you and in many cases love you.
That's been one of the things about the lifeboat that I think surprised me the most, and I think it was probably the same with Mark, is that earlier on you were saying that addicts aren't bad people. They're like everybody else. I've always maintained that once you get an addict out of the life, it's going to sound crazy, but in many cases, I feel like they're almost better than most people. And the reason I say that is once they get out of that life, the one thing they all seem to bring with them is a level of compassion that the rest of the world doesn't have. Most of the people that I've encountered on the lifeboat, the level of love and caring for one another. One of the real things that, jumps out at us is that if somebody misses 2 shows, right, I'll get 14 emails. Hey, where the heck is so-and-so? Has anyone tried tracking them down? And I mean, we do 7 shows a week at a minimum. Sometimes just something comes up and someone will miss a show, but everybody here is concerned that, maybe something happened to this person and we need to reach out to them. Doc, one of the things that you just said that I think I'd like to sort of reflect on is the real difference between the way that Suboxone is administered versus the way that methadone traditionally is, because this is something I dealt with. When you're on methadone, you show up at a clinic every single morning, right? And it's very often, the clinic opens at 5 a.m. And when I first tried to get clean, I was working as a public speaker and I was making really serious money. At that time in my life, the wage was about 30 grand a month. And I was standing online in a suit and I was looking at the people around me, and it just caused me to think to myself, well, I'm not like these people. You know what I mean? Like I started to think of myself differently as an addict. When I met people in the Suboxone treatment, mode, I was like everybody else there. Even, you know what I mean? They didn't make you feel like there was this division of there was something just really awful about the whole method of how methadone is given out. I think so. You worked as a doctor working one-on-one with people, correct? With Suboxone. It's just that model to me, like you talked about, this being a disease. If you go and you get a prescription for insulin, you don't feel odd going to get a prescription for insulin. Or if you get a prescription for high blood pressure medication, you just feel like this is something I need. I'm going to go and I'm going to see a doctor. My problem with methadone was that that's not how I was treated. You know what I mean? And I stuck out like Wednesday in the middle of the week. Everybody on the line was staring at me like, this guy's a cop, right? What's this guy doing here with a tie on? It was just a really kind of a different setup. And I think for anybody listening, you need to pay attention to what the doctor's saying, because once you start being treated like a human being, once you start getting treated like someone who just has a medical problem, for me, Doc, that was the beginning of everything great that happened to me. I remember going to see the Suboxone doctor the first time, and I said to them, how often do I have to show up for drug tests? And the guy said, why are you planning on doing drugs? Like it was almost a shocker on his part. Well, why are you planning on getting high? And I said, no. He goes, well, maybe we'll hit you once a month, or maybe we'll get you every other month or whatever. But, if by some chance, you use, please just tell us. And when you're treated with that level of trust and respect, I think that really changes, sort of in the mind, how you're viewed changes how you feel,
I think just as important about how other people treat you and feel about you is how you feel about yourself. I mean, after you've been kind of beat on verbally by society, you start thinking, well, I'm a bad person. You start buying into that yourself. You start thinking that you're worthless, that you're no account, that your life's wasted. I've heard it all. And that's a horrible way to feel about yourself. The way you feel about yourself in many ways, kind of predicts where things are going.
No question.
You need to love up on yourself. You need to like yourself, and you need to be your own best advocate.
No, I can't agree with you more on that. And that was another thing that was really different with Suboxone is I felt like I was allowed to be my own advocate. I know I'm probably sounding like just somebody that's really beating on the methadone model, but if I had gone to one clinic, I could say, well, I probably got a bad clinic. I went to 5 of them, right? Over the course of the time I was trying to quit, I was in 2 different states, and each time I went to one in a state and said, oh God, this is awful. I'll try one in a different part of town and maybe, but every time I told them I wanted to step down in the dosage, they talked me out of it. They told me that I wasn't ready for that, that was way too early on in the process. When I told the Suboxone doctor that I worked with the first time that I was thinking of stepping down in dose, their response was fantastic. That's great. Let us know though, if the cravings start or if you're running into any of these things. It was such the dichotomy between the two was like night and day. I almost felt, Doc, like the places that disperse methadone seemed like drug dealers. I'm just being honest. And the people that dispense Suboxone seemed like a doctor who is very active in your care. I once spent a year and a half in a methadone clinic and saw a doctor once. I have never gotten a prescription for Suboxone without seeing a doctor, where in a methadone clinic, you see a doctor the first time and you might go a year and never see him again. It just seems like I don't know. It seems like a bad model compared to what we're doing with Suboxone.
Yeah, I think in terms of decreasing your dose when you're on Suboxone, I mean, my feeling, and I think the feeling of most physicians, is that's totally decided by the patient. And every course is going to be different. And I tell my patients that, their path is going to be unique. Say I usually take people down a couple milligrams and then see them in a month and see how they're doing. If people have cravings, I may raise them back up. So their course, well, I'll go this way because the way you're looking at it, their course isn't like this. It may be like this up here, but eventually you get where you're not taking the drug. But it's totally dictated by how the patient feels. I don't have a test to know how you feel, Tommy.
Right.
I mean, I don't have a craving test but so I'm totally dependent on what you or anyone else would tell me. And that pretty much dictates how things go when you're trying to taper.
Here's another thing that comes up often when I do shows on Suboxone. There are, I don't intend to get off this. And there are people who feel like, I traded one drug for another. I have gotten down to where I take 8 milligrams a day. And when I do heroin, I am such a different human being. I'm a reprehensible human being. Now, I really am. And I know that deep down I'm not. But once I start to take heroin makes the decisions. And the things that I do on that drug are just foul. And I've gotten to the point where I do view this like heart medication. And for me, I don't feel a buzz. I feel absolutely nothing, but I get no craving. And even during downtime or when there's nothing going on, my brain never goes back to that craving or that fantasizing or that thinking about. So for me, it just makes sense that, I think I'm at $60 a month, right? I had a $700 a day heroin habit and I don't make bad decisions on this. How do you view people that think maybe this is just something I'm going to take for the rest of my life?
Well, I agree with you totally. In fact, when I went to work for groups, I noted in the literature and in, the courses that the public, the courses that, you could read about, or magazine articles and medical journals, that if people taper all the way off of Suboxone, within 2 or 3 years, 95% of them will be back on whatever drug they were treating. So my feeling was, why taper off if you're doing fine? The drug is not expensive. People are not getting high on the drug. You're basically taking the drug to get rid of cravings, and so you can function as a normal person. But that wasn't the feeling of groups. This is 4 or 5 years ago. They said, no, after you've been on for a year, we need to taper. That's a recommendation. And then they said, well, after a year and a half, we need to taper. Then they said, well, after 2 years, we probably should taper. And now I think groups and most addiction physicians have the same attitude you do, which is $60 a month, that's nothing. And you're living a productive life. You're not getting high. And look at the cost to society besides just the cost of the drug. If you didn't have the money for heroin, what are you going to do? You're going to steal
Amen.
it.
You're right.
You're going it's millions of dollars of stolen property, prostitution. And these are not criminals or bad people. These are people that are forced to do this because of the opioid receptors in their brain. I mean, they're not bad or immoral people. You can tell they're not crooks because they're so bad at it. You know, they always get caught. I mean, they're not mastermind criminals. They just want some Oxycontin, and they need money for that. So I think that this is the direction that addiction medicine is heading, and I think it's a good direction. Just like if you were a diabetic, you'd take a certain amount of insulin every month forever. I have patients ask me, somebody that maybe had hypertension. I was a family doc for 2 years before I specialized, but they'll say, "Doc, how long do I have to take this?" And I said, "Forever.
As long as you want to live."
Yeah. To your last breath, that's how long you're going to take it. And I think there's nothing wrong with taking Suboxone. And I don't think you're not substituting one drug for another. They're two different, Suboxone is totally different drug than heroin or Oxycontin or hydroxycodone or Lortab or whatever, fill in the blank opioid. So maybe to your surprise, I agree with you totally.
You know what? Go ahead, please.
Yeah, I think from my end of it is like when you're talking about using the medicated assisted treatment, the key word there is assisted, because I do think it takes a level of peer help to really get you in a healthy place. And me and Tommy, we talk about that moment of clarity. If you can't get that, you're never going to know which direction to go. And that's, I do think that, Suboxone really does kind of provide that for a lot of people. They're able to not have to worry about the withdrawals. They're not having to worry about trying to go chase down what they need so they're not sick. And they're able to step back for a second and be like, man, I really don't want to live that life anymore. And right. In these facilities here that we're talking about, like groups, I love the direction of it. I can't tell you how much. I know this sounds crazy, but I was in recovery for 9 years, right? Before I found groups. I've learned more and I feel better just in that, from the time I found them till now, than I ever did 9 years before. I would legitimately get nervous and like sick to my stomach when I would have to go pick up my script at the other facility, because there was always issues and nobody really would address it with you. I mean, if you had a problem, it took you a week to figure out what was going on. And being able to not have to have that issue, it really does make a big difference, because the chase is probably one of the worst parts of addiction together anyway.
No question.
But I would also ask, it affects the family, the kids, that kind of a thing. These guys are parents, they're moms, they're dads. It blows my mind, some of the stuff that we have to try to explain on that end of it. And it hits everybody. This opiate crisis did. I'm not sure if Dr. Jetmore remembers the billboard here in town where it says pick out the opiate addict, and it's a bunch of different careers, right? And you can't pick it out because there's, legitimately. Everybody. And Tommy spoke about it a second ago with showing up at the clinic with a suit on. So that it's everybody. And I think that this has forced our society to look at this thing at a hard level. And it really has. It's been a positive thing. And I do think that some of the stigma is going away. I mean, what do you think about that, Dr. Jetmore? Do you think the stigma is starting to come down a little bit on that, or is it?
No, I think the stigma is coming down. I think more and more people are aware of the tremendous toll of overdose deaths each year in the United States. And, the horrible thing the Sacklers did. There's been all kinds of documentaries on how the Sacklers basically addicted a great number of Americans on purpose to OxyContin for money. And many of these people, that they got addicted, ended up dying. So I think people are more aware of that, and they're more aware of the fact that people don't choose to be addicts. I mean, nobody gets up and says, you know what? It would be really great to be a heroin addict.
Boy, wouldn't it?
Wouldn't it? What a great life that would be. I'd like to do that. No. And so I think people have changed. I think there was an earlier time, and there's probably still some people that feel this way, that, why don't they just quit taking drugs? That is such a simple-minded approach to, the whole just say no attitude toward curing a problem is not one that works. But the idea that people who are drug addicts are somehow inferior to other Americans because they're bad people, because they have a weak will, I think that people are starting to come to the realization that these are normal Americans that, for whatever reason, became addicted to drugs and are now drug addicts. And I think one of the things that, and you alluded to this, Mark, is, everybody knows, everybody's got a relative or a friend that's overdosed or is struggling with addiction. It's not, some guy in New York that you heard about on the news. I mean, it's just all around us.
Yeah, it's definitely touching.
That's made us face that reality that, when you see a cousin or a niece or a daughter struggling with drug addiction, it makes you sympathetic with all drug addicts.
I think that gets left out a lot. So thank you for saying that, because we have to understand that these are mothers, fathers, brothers, sisters, moms, dads. I mean, all of it. Co-workers. It doesn't matter. Really, just they're people we care about. And you said a minute ago, nobody chooses this. This isn't something we wake up and, I'm going to go chase the dragon. It ain't nothing. I mean, there's just nothing you want to do there. It's ridiculous to think that way. I mean, I understand, okay, to the point where I probably used to be one of those people. And I'm being honest, before I was addicted. And I think it takes people like yourself and groups and everybody that's trying to do it the right way here to change that. And I'm pretty sure you've seen a pretty good turnaround in the whole industry, at least a little bit. You know what I mean?
Mm-hmm.
Because I've seen it myself, so I couldn't imagine with you being, one of the county health officials, that you have to see it. I would think. I don't know. Maybe you can talk about that a little bit. Your capacity there and what you see kind of on that end of it.
One of the things that we've pushed here in Wayne County is, and I've pushed this as a health officer, and so is my medical director, is giving people free Narcan. And this, there's 92 counties in Indiana, and I think 11, 12 or 13 counties do that. Only 10 or 12 counties. I can't give you an exact number, but it's right in that ballpark. Now, this is a cheap drug that will save another human being's life. And a year ago, they used to make us apply for this license with the state every year. And we would go down to the council building and argue in favor of having Narcan. and needle exchanges. We have needle exchanges and try to educate people about not sharing needles and about proper disposal of needles. And the county prosecuting attorney always comes down and argues against this and says, because we're providing needles, we're encouraging people to use heroin, which is so stupid. I mean, I grew up on a farm, and I would go down to the elevator and get syringes and needles all the time to medicate cattle, hogs, and cows and sheep. And I never got the urge to give myself any of that sheep medicine, even though I had it right there in the syringe and the needle. This year we got it for 2 years. But, that whole law that, about drug paraphernalia, somebody in the State House decided you needed a needle in order to inject heroin. So what we'll do is we'll just outlaw needles. Well, that was not the way to approach this. That didn't stomp out heroin addiction. It just made the problem worse. It had the unintended consequences of needles becoming scarce and people sharing needles. Now you've got hepatitis C everywhere, and in some cases AIDS spreading from these needles. So, we can back up the success of this Narcan and needle exchange when we give people free use of Narcan. You can come down to our county jail at walk-in, and there's a machine that dispenses Narcan, just like a candy machine or a cigarette machine. You pull down a lever and your Narcan comes out and you leave. It's totally anonymous. There's nobody else there. And the amount of deaths we have from overdose has gone down since we've done this. And it's down compared to counties that don't have these kind of programs. And the amount of, we can track the number of people that have hepatitis C or AIDS, and that's gone down as well. So we can see the effects of these programs. We're wanting to help people. We're in the business of seeing that people don't have disease and don't die.
Right.
I
think one of the things that you get that people lose sight of, and by people I mean society, and I'm with Mark. Before I really got strung out, I was one of those guys that said lock them up and throw away the key, and then I ended up locked up, and I sort of saw this from both sides of the equation. But here where I live, the needle exchange programs, the reason that they give those needles out, it absolutely reduces disease. But what it does most of all is it builds trust. When someone goes in and says, here's 200 dirty needles, and the needle exchange program gives them, a box of clean needles in exchange, they also then say here, and they hand you 3 pamphlets. And I remember the first time I heard about Suboxone, it was at a needle exchange. I went in and dumped off a whole bunch of needles. And I could afford needles. I did it because I didn't want to walk into a pharmacy and say out loud, hey, I need needles, right? So the needle exchange program for me was just a really great way of sort of hiding. But the woman said to me, hey, and she didn't press me or anything else, but she said, if you ever want to get off that stuff, they got something way better than methadone now. And she handed me a pamphlet on Suboxone. And I think this is one of those programs that really kind of allows outreach. I remember going to a pharmacy once to pick up needles, and the doctor said to me, what kind of insulin are you using? And I said to him, I'm not using insulin. Like, I'm not going to lie to the guy, right? I said, I'm not using insulin. And he said, hold on 1 second. And I was standing there waiting for my change. And he came up and put a bottle of Narcan on the counter. And this was at a time where you couldn't get Narcan in this state, right? It wasn't legal. And this was just someone that cared. He was someone that was going to get, Narcan into the hands of somebody that might do some good with it. And he said, there's a little pamphlet in there with some instruction, but I'll tell you something right now, that bottle saved 2 people. And it does take people to kind of think outside the box, but it is a ridiculous concept to think by the fact that you're giving someone a needle. No one ever thought, hey, there's a needle exchange on 3rd Street. I think I'll just start buying dope. You know what I mean? It's not something that encourages drug use. That's the dumbest thing I've ever heard. But it's a society that doesn't get it. Doc, there's one question I really wanted to make sure that I asked you, because I think this is really kind of right in the wheelhouse of what we talk about here on the Lifeboat, and what a lot of people, I think, might miss. So if I get off of Suboxone, or if it were, let's say I've never done Suboxone and I was on heroin or whatever, those defective receptors, that are craving these, they ever going to get better? They ever just going to heal by the fact that I stop using?
No. And I wish I didn't have to give you that answer, Tom, because I know people would like me to say, well, wait a minute. What if I don't take anything for 20 years? Well, no, they're changed, and it's like, you can't unburn a burnt bridge.
Right.
You can't unring a bell, and that bell's been rung, but that's not the end of the world. Okay. We got each other, and we got this medicine, and it's a wonderful world out there for all of us to enjoy.
Well, I think knowledge is power too. Knowing that it's one of the reasons that when people say to me, boy, when do you plan on getting off that stuff? And they always look at me crazy when I go, I'm not. I have no intention of ever even trying. And I know that I get strange looks, but see, I do know the answer to that question before I asked it. My receptors aren't ever going to change. And
no, and I say that for people that there's somebody out there that's not going to have taken any narcotic for 10 years. They're at a New Year's Eve party. They run into their cousin and they say, here, go ahead and have some of this, Bill. And Bill says, well, my receptors probably can handle this now because
I hadn't done it in 20 years. I'm good.
No, you're not good.
Yeah.
So stay away from what Bill says at the New Year's Eve.
And I have found, and I've said this to people before, and I know it doesn't make sense to people, but I have not only read this, I've lived it. Let's say he takes off that 20 years, and then Bill gives him that. Not only are those receptors active, right, the way they used to be, but that addiction has been growing the entire time without you. You know what I mean? Like, people think, well, even if I were to go back, I was off for 4.5, 5 years. And when I stopped, I had about a 3 gram a day habit. So when I came back on, I did a $10 issue, right? $10 got me high. In 2 weeks, I was doing 700 a day, because my addiction didn't take a vacation. My addiction continued to grow. I took the vacation. And once I added that dope back in there, it was like, where you been? I went from $10 a day to $700 a day. I'm not kidding you, in 2 weeks. And I know this doesn't make sense to the average person that tries to think about it. It doesn't make sense to me, but I promise you it's the truth. that addiction is in there, and it's raging, just waiting for you to feed it. It's sad, but true.
Now, can we, like on the pain end of it, say one of us that are in recovery, we have a bad car accident. We go to the hospital, we've got a broken back, neck, or whatever. What can we expect? I mean, as far as getting any kind of help with that?
Well, this question comes up all the time, people who are injured or people who are going to have surgery. And basically what I do is take people off their Suboxone, have their doctor treat their pain with whatever seems appropriate. And, that pain is short-lived. When I say short-lived, I mean, it's not chronic pain. It's acute pain. You got you have an incision for surgery, that pain's going to be resolved in a week. Most of it, that the pain that you have left, that incisional pain, can be treated with Tylenol or aspirin or, But then when people come off that medicine, then they go back on their Suboxone.
Is it harder to treat somebody for pain that has been on this for a while, or do we build a good tolerance against some of those medications?
Yes, you do build up a tolerance, and you may need a higher dose than somebody that hasn't been around opioids, for instance. But the doctor, any doctor can, take that into account, treat you to your pain, so that your pain's controlled. You get over the surgery, you get over the injury, and then you go back on your Suboxone.
Okay. I guess, because that's a question even from me, is it, I guess what I'm trying to say is it, there's no, like, if we're on Suboxone for a while or any kind of recovery withdrawal medication, we're not like stuck out in the cold. They're going to be able to treat your pain, right?
Sure.
Okay.
Sure.
Because I know that's a common fear in this community. It really is.
Yeah.
And it's a question that I think a lot of people are afraid to ask for some reason.
Well, I'm glad you asked it then. But no, we're always going to be able to control pain, whether you're taking Suboxone or even if you were somebody that's a heroin addict and is coming in for surgery. We're going to control your pain.
I said I've been in recovery for, you guys know how long, 10 plus years, and that's that has been one of my concerns. God forbid, like I say, go out and have a car wreck or something, and I've always been afraid of that. And I've had a lot of surgery, so I know exactly what you're talking about with the after surgery type of thing. It's not a chronic pain; it's a incisional pain, and I think that those of us in recovery, we have to recognize that we tend to lean towards, I want more of that to help me feel better. We got to guard ourselves against that, and I do think that's a real issue with the whole pain thing when you're on recovery medication, which is why that's why they guard it so much, I would think.
Yeah. Well, the other thing is, part of this dealing with pain is a cultural thing. Opioids are for pain, opioids for pain. For the whole world, I think we're 5 or 6% of the world's population.
Yeah.
I think we probably use 80% of the opioids.
Yeah.
Why is that? Because we don't want to hurt. Doctor, I don't want to hurt. And I grew up on a farm. Well, I still live on a farm. Something always hurts. A cow drives you into the wall of a barn. You slip and hit your thumb with a hammer. I mean, there's always something that hurts. And you basically, that's not, a lot of pain is, well, hell, that hurts, but it'll be okay in a day or two. That decision that it's going to heal up and be okay goes a long way toward treating your pain. It's a lot of pain treatment is attitudinal, and Europeans, Asians, they assume that they're going to have a certain amount of pain in their life,
and then it'll go away. And in America, we say, make that go away. Yeah, no, there's no. Well, and here's the other thing: there are of all of the nations on the planet, I think there are 3 of them that allow for television advertisements for drugs. Like, I can't walk into a pharmacy today and say, hey, I want some of that Lyrica because I got restless leg syndrome, but they'll run that ad 15 times a day, right? So I think we're getting into a culture now where when you go in to see your doctor, instead of saying, let me tell you what's going on, doc, people walk in and say, I got restless leg syndrome, I need that Lyrica. It seems really odd to me that we run advertisements for something that we can't buy, right? So we're influencing how people go in and talk to doctors now, right? Now they go in saying, this is what I need.
Yeah,
WebMD too, right?
And they've gone directly to the patients to advertise their wares. What always amazes me is that at the end of the thing, they say, as quickly as they can, this can cause sudden death. Your right arm may fall off. You may have diarrhea for years. And it just keeps rolling and rolling. But these same people won't get vaccinated for COVID.
Yeah,
and by law, here's the crazy thing. By law, they've only got a list. I can't remember whether it's 5 or 7, right? I did a deep dive on all of this advertising stuff, and there's a certain number of side effects, possible side effects that you have to list. And the crazy thing is the list might go from here to Baltimore, but they've only got to randomly pick. They have to put one in there. Like if death is one of them, they got to list that. But the rest of them, they're randomly picking it. And I hear some of them and I think, damn, these are the ones you chose, right? What are some of the ones you didn't pick? Because there's got to be some really ugly stuff out there.
What about people that have real chronic pain? How are we supposed to view that now as a society? Is that something, I mean, just your opinion on it, obviously, but I think that's a real question and a concern that I know that a few of our crew members here have, because there is real pain people have to deal with, and what's acceptable and what's not as far as pain level from your point of view.
Well, you know, what I was talking to you before about something always hurts, that's always pain that goes away. Okay. But chronic pain by definition is pain that you're going to have forever. And if it's keeping you from functioning as a person, then that pain needs to be treated. And those people should be treated with whatever it takes to control their pain. And I would go in, if I were a patient like that, I'd go and see a pain doctor. You know, these are docs that, you know, this is their strong suit, treating patients with chronic pain. I mean, the average doc is maybe not as skilled or as knowledgeable or have as much experience as a pain physician, but they need to be treated.
Okay. I mean, like, I guess, and from my end of it, say, you know, I'm on Suboxone or whatever withdrawal medication that I'm currently on, and maybe I develop a chronic thing. How does that work for us? I mean, is that something that we can still address, or is it something we should really just not even do?
No, I think it's something that if you have chronic pain and you're also on Suboxone, one of the things is Suboxone does have some mild analgesia properties. In other words, it'll give you some relief from some mild chronic pain. But this is a problem that you know, pain doctors face all the time, and I would consult with those guys, and they'll have an answer.
Okay, because I don't want to leave out the fact that I guess we're calling it Suboxone, and really probably we're more so talking about buprenorphine, because you get Subutex and also all that other stuff that's out there.
Yeah.
You know,
Vivitrol.
Yeah. So I just want to clarify that from my end of it. I didn't know if that was an issue that people don't quite understand the difference, is what I was trying to say. So, but yeah.
Well, I think one has Narcan. Yeah. And but I've always read, Doc, the same thing, that, you know, they say it has a very mild, analgesic effect in terms of pain. But I'll be honest with you, you know, I've had multiple back surgeries. I've broken my neck, my back, and, you know, I was in a pain management for a really, really long time. And it was one of the things that led to my heroin addiction. But my pain is now controlled. I mean, it really is. Like, I get, when I feel like, boy, I really need to take my Suboxone, it's usually not because of feelings of withdrawal or anything else, but it's, you know, feelings of pain. And, you know, if I forget for whatever reason, that's usually what sets it off. It's not the withdrawal symptoms or anything else, but my back will start going and I'll think, oh man, I bet I didn't take that this morning, you know, and then I'll go and I'll count it. But I actually get a fairly decent amount of pain relief from Suboxone. Now, I don't know if it's partly mental or whatever the case may be, but I definitely, I do pretty well with it as a pain management.
No, it's probably not mental. It's probably physiologic, but, you know, all pain, you know, pains are all different. And you're fortunate in that the pain you have is amenable to the Suboxone.
Oh. Yeah, I do feel blessed that way. There's no question, because
we're coming up on the hour mark. So if you want to kind of try to wrap it up, just so everybody know my technical.
Okay, perfect. Yeah, I'll tell you something, Doc. I can't begin to tell you how happy I am that you've come on here. There, you know, a lot of the stuff that you talked about today, I think is probably going to be eye-opening for a lot of the people on the boat, because, again, and I understand this, by the way, but Mark and I don't have any credibility. You know what I mean? We both take this substance. So, when we talk about Suboxone, everything we say is sort of tinted with that, that lens. And I think it's a real benefit because there's a lot, we get so many questions from people who are addicted to opiates, who are considering, going into some kind of medical assisted treatment. And, they can take what we say with a grain of salt because both of us are on it. But I think it's a great thing that you've come in here and talked to us. I really do appreciate it, Doc.
Well, I'm glad you had me, and I'm glad to be here. And maybe I can come back if you accumulate a bunch of doc questions.
Yes.
You know what? I would imagine that will happen. And knowing that we were going to be doing this today, people, I actually held off because I don't know if this has ever happened, but that right there is a strip of Suboxone. We talk about these things and we describe it, but looks like the old breath strip, right? When they talk about taking this stuff, it's just a sublingual film that goes underneath the tongue. Boy, it beats heroin. I'll tell you what. If you got to trade one for another, this is a pretty good trade. Doc, thanks again. I really do appreciate you coming on.
Thank you, guys.
And I would look forward to having you on again. People, I'm Captain Tommy Scoville, and on the other side of the glass is my partner,
Mark Wages.
And as always, and I do mean always, this is a cat in a basket. All right, people, have a great day.